paraneoplastic syndromes and renal cell carcinoma. So first, some obligatory epidemiological facts. There are 65,000 new cases of RCC diagnosed annually in the United States. It accounts for between 2 and 3% of all adult malignant neoplasms. Among the common urological cancers, it is the most lethal. The 5-year survival quoted around 71%. Typically strikes later in life and has a propensity for the male gender. And risk factors include tobacco use, obesity, hypertension, African American descent, and various congenital syndromes, VHL, tuberous sclerosis, Burke-Hogg-Dubé, etc. Renal cell carcinoma is derived of renal tubular epithelial cells. Aside from their normal physiological excretory function, these cells also have a variety of secretory functions. They are responsible for the conversion of 25-hydroxylated vitamin D to 125-hydroxylated vitamin D. They are responsible for the secretion of renin and the triggering of the renin-angiotensin-aldosterone cascade. They produce erythropoietin to induce red blood cell production in the marrow. And they're also responsible for the production of various prostaglandins and other vasopressive substances. Under normal homeostatic environments, these are all very tightly regulated function. However, in the malignant neoplastic environment, dysregulation of the secretion of many of these substances can be responsible for a variety of paraneoplastic syndromes. So I think it's worth kind of touching on before I really dive in on what qualifies as a true paraneoplastic syndrome. So this is an article that came out of the World Journal of Urology this year that I found very useful, entitled Rare and Changeable as a Chameleon, Paraneoplastic Syndromes in RCC. They define a paraneoplastic syndrome as a set of signs and symptoms triggered by a malignant tumor which cannot be associated with its primary site or site of metastasis. By definition, it's a diagnosis of exclusion. It can't be secondary to infection. It can't be secondary to side effects from medical therapy. It has to be due to either direct humoral secretion from the tumor itself or secondary to the body's immune response to that tumor. In this article, they performed a very expansive literature review, and they came up with a very wide reported incidence in paraneoplastic syndromes in patients with RCC, between 10 and 68%. So this kind of is not a very useful range of incidence, and I think what it reflects is there's some inconsistency with what actually qualifies as a paraneoplastic syndrome, and there's also probably some inconsistency in the reporting of paraneoplastic syndromes as well. So it's useful to break down paraneoplastic syndromes and renal cell carcinoma between endocrine and non-endocrine forms. So briefly, I'll touch on some of the reported syndromes and their corresponding mediators before going into some detail. So the first syndrome, Cushing syndrome, is associated with renal cell carcinoma secondary to erroneous production of ACTH. Hyperprolactinemia and gynecomastia have been reported in the literature secondary to excess production of prolactin and beta-HCG. Hypercalcemia is among the most common paraneoplastic syndromes in renal cell carcinoma. This is due to a variety of mediators, including inflammatory cytokines such as IL-1 and 2, but also erroneous production of parathyroid hormone and parathyroid hormone-related peptide. Diabetes and conversely hypoglycemia have been reported due to excess production of glucagon and insulin, as well as hypoglycemic effects of various inflammatory cytokines. And carcinoid syndrome has also been reported in the literature due to serotonin production. Hypertension and polycythemia have been reported secondary to the erroneous production of renin and erythropoietin. Erythropoietin not only being responsible for the production of red blood cells, but also it does have direct vasopressive effect. And then finally, some more constitutional symptoms are commonly reported in paraneoplastic syndromes for RCC, secondary to a variety of inflammatory cytokines in the context of this malignancy, IL-6 being one of the more common, as well as ferritin lactoferrin. As far as non-endocrine paraneoplastic syndromes, there are a variety of mucocutaneous syndromes that have been reported. and we'll kind of look at these in detail later on. But the proposed mechanism by which these proliferate is largely due to tumor secretion of TGF-alpha. There are some very interesting neurological paraneoplastic syndromes in the literature reported. By and large, these are generally mediated by autoantibodies that are produced as kind of side effects of the body's response to neoplasm. And diagnosis of these is aided by detecting antibodies in the CSF analysis. Finally, there's the eponymous Stauffer syndrome, which is a hepatological dysfunction associated with renal cell carcinoma. There are several theories as to the pathomechanism of this illness, but it's not fully described. And finally, other constitutional symptoms are associated with IL-1, IL-6, and tumor necrosis factor B. So the first syndrome that I want to talk about in detail is hypercalcemia. It's the most common paraneoplastic syndrome in renal cell carcinoma. Literature reports its incidence at about 7% in local stages of the disease. This increases to between 13 and 20% in advanced stages. Looking at the syndrome kind of from the other perspective, about 75% of patients with hypercalcemia and RCC have advanced local tumor stage, and about 50% will have bony metastasis at the time of presentation. I think it's pretty worth mentioning that a significant subset of patients with hypercalcemia in the setting of renal cell carcinosis do not qualify as having a paraneoplastic syndrome if their hypercalcemia is due to bony metastasis. So I think that's a pretty significant confounding factor with a couple of the above statistics quoted. But pure humoral hypercalcemia absolutely does occur in renal cell carcinoma. This is due to the erroneous production of parathyroid hormone or parathyroid hormone-related peptide. Interestingly, the wild-type VHL protein normally suppresses the secretion of PTHRP. The VHL protein is the VHL gene is a very common site of mutation in the genesis of renal cell carcinoma, and so its loss is understandably associated with excess production of PTHRP. Excessive conversion of 25-hydroxylated vitamin D to 125-hydroxylated vitamin D is also described as a contributing factor to hypercalcemia, leading to increased gut absorption of calcium. And finally, a variety of inflammatory cytokines produced as part of the body's response to neoplasm have osteoclastic activity and lead to increased bone turnover and hypercalcemia from that source. This is just a quick diagram of the mechanism by which PTH and PTHRP might increase calcium in the blood. They lead to increased calcium reabsorption in the kidneys, increased vitamin D synthesis, and therefore increased calcium absorption in the intestines, and lead to increased efflux and bony turnover due to osteoclastic activation. So signs and symptoms of hypercalcemia: weakness, headache, cachexia, nausea, vomiting, constipation, things like that. The kind of classic moans, groans, and psychiatric overtones that we all learned in medical school. Typically, hypercalcemia in the setting of renal cell carcinoma is responsive to nephrectomy, and that's going to be a trend that you kind of see throughout the talk here. However, if desired, preoperative management of the hypercalcemia can be performed using medical therapy, loop diuretics specifically, as well as bisphosphonates and calcitonin. The next syndrome that's very commonly reported is hypertension. It occurs somewhere between 14 and 35% of patients with RCC. It is typically associated with lower grade clear cell tumors, and it's mediated by neoplastic proximal tubule secretion of renin. It's also mediated in part by exogenous erythropoietin production, which, as I mentioned earlier, has direct vasopressive activity. Similarly to hypercalcemia, there are non-paraneoplastic contributions that can lead to hypertension in patients with RCC. Specifically, direct compression of the renal arteries by a mass can lead to decreased GFR, which will cause a physiologic increase in renin Because this increase in renin is due specifically to the mass effect of the tumor, it's not considered a paraneoplastic syndrome. Going down the line, polycythemia is also another common syndrome seen in RCC. It occurs in somewhere around 8% of patients. Again, there's a kind of nice genetic pathway that's associated with polycythemia and renal cell cancer. Inactivation of the VHL gene has been demonstrated to increase HIF-1A. This leads to the overproduction of various endothelial growth factors, as well as excess EPO secretion. Interestingly, when kind of looking at the literature, actually between 60 and 70% of patients with RCC do have elevated levels of EPO. However, the vast majority of this is an inactivated version, and which kind of accounts for only about 8% have clinically relevant polycythemia. Symptoms include nausea, vomiting, pruritus, and headache. More clinically relevant kind of outcomes of polycythemia as far as an operative patient go are increased likelihoods for stroke and pulmonary embolism. So this is a paraneoplastic syndrome that's worth kind of considering in the preoperative setting because it can kind of be, the risks can be mitigated by early treatment with controlled bleeding. Stauffer syndrome is one of the more interesting and widely described paraneoplastic syndromes in RCC. It's also known as nephrogenic hepatomegaly. Kind of textbooks quote somewhere around 13% of patients with organ-confined RCC as having Stauffer syndrome, and then up to 20% in all stages of RCC. There are a variety of kind of definitions that go into this syndrome: hepatic dysfunction, nonspecific hepatitis with lymphovascular infiltrates, and a variety of hepatic biomarkers have been suggested to be used for diagnosis of Stauffer syndrome. It's important that whenever some sort of hepatic dysfunction is considered in RCC, you have to exclude hepatic metastasis. Unfortunately, the direct mechanism of how renal cell carcinoma can contribute to hepatic dysfunction isn't really greatly described. There have been theories that direct secretion of tumor hepatotoxins exists. Unfortunately, these hepatotoxins have not been specifically described. And then the kind of reigning theory is generally due to elevated prostaglandin and IL secretion can contribute. Typically, these patients have resolution with nephrectomy. About 60 to 70% of patients resolve following nephrectomy. And persistence of Stauffer syndrome following nephrectomy is almost always indicative of the presence of viable tumor. More recently, however, there was a comprehensive review published in Urologic Oncology in 2017 that aimed at kind of regenerating the diagnostic criteria for Stauffer syndrome. And so this is a comprehensive literature review, and what they did is they tried to isolate signs and symptoms that were very reliably demonstrated in patients diagnosed with Stauffer syndrome. And they actually came up with two variants of the syndrome, a jaundice variant and a non-jaundice variant. They found that biomarkers associated with hepatobiliary ductal dysfunction were reliable predictors of patients receiving this diagnosis, such as ALK-Phos and gamma-glutamyl-transferase. They also found similarly dysfunction in biomarkers used to describe hepatic synthetic function were reliable indicators of the disease as well. In the jaundice variant, they found hyperbilirubin, jaundice clinically, and urine hyperpigmentation as being reliable predictors of the syndrome. What's noticeably absent on this list, however, is the omission of biomarkers associated with hepatic damage. So you will not see transaminases on this list, and they did not find that transaminases were reliable predictors of a patient receiving this diagnosis. So this is in direct contrast to some of the kind of predominating textbook definitions of Stauffer syndrome currently kind of circulating. So that was pretty interesting. Moving on, although there are many mucocutaneous paraneoplastic syndromes associated with RCC, as I kind of alluded to earlier, the proposed mechanism by which these erupt is due to increased tumor production of TGF-beta. I've included a picture of erythema gyratum repens. This is kind of an interesting one, very marked concentric circles, kind of looks like the cross-section of a tree. Ichthyosis vulgaris is reported, as well as pemphigoid, kind of described as very angry-looking blisters, as well as adult Still's disease. Still's disease, typically referred to as idiopathic juvenile arthritis, can occur in adults with RCC and other malignancies as well. This was a really interesting case report that came out of autopsy case reports in 2016 that looked at a case of acanthosis nigricans in a 67-year-old female with clear cell renal cell carcinoma. This was a patient that presented with 10 months of some constitutional symptoms, as well as some pretty discrete darkening in her axial and her neck region. She was found to have a 13.4 centimeter palpable renal mass. And following resection, 50 days post-op, she has a really kind of impressive resolution of her dermatologic symptoms. That was kind of interesting. Another case report of some more rare mucocutaneous syndromes associated with RCC. This comes out of case reports in dermatology in 2015, and it's a case of Lesser-Trillette syndrome in a patient with RCC. So classically, Lesser-Trillette syndrome is described as an eruptive seborrheic keratosis that's pruritic in patients typically with GI malignancies. This patient was found to have a left renal mass, and after undergoing extensive workup, was not found to have any sort of GI malignancy. This is one of the first reported cases of Lesser-Trillette outside of that. Unfortunately, they did not report on the outcome of the patient, so I can't report on whether or not this syndrome resolved following nephrectomy, or if the patient even underwent surgery. Another interesting case report that I came across is published in the Journal of Endourology in 2018. This is acquired von Willebrand disease as part of a neoplastic process in renal cell carcinoma. This is a 46-year-old male presented with gross hematuria, underwent cystoscopy, and was found to have active bleeding from his right UO, and actually required reintervention due to pulsatile bleeding from a vessel in the bladder. Further workup actually found a left renal mass, so not contributory to the active bleeding from his right UO. This led the patient to undergo a bleeding diathesis workup. It was found to have von Willebrand's disease, no reported family history. Following a radical nephrectomy, his von Willebrand's fracture antigen normalized, and his PTT normalized as well. This was an important perineoplastic syndrome to recognize preoperatively for obvious reasons, and this patient underwent pretreatment before his nephrectomy with IVIG and humate. Blood glucose abnormalities have also been described several times in the literature as perineoplastic processes with renal cell carcinoma. Case series coming out by Delano and colleagues in 2018 described 5 cases from 1997 to present of hypoglycemia in renal cell carcinoma patients. This is likely secondary to tumor production of IGF-2, which acts similarly to insulin. And 4 out of 5 of these patients had resolution of symptoms following resection. Similar case report by Gap and colleagues in 2018 described 7 cases of hyperglycemia between 1980 and present. The pathomechanism behind this syndrome is secondary to either tumor secretion of glucagon or autoantibody formation in the setting of malignancy against islet cells in the pancreas. Additionally, various cytokines such as IL-6 and even cortisol can lead to decreased glucose uptake in the periphery, which can contribute to hyperglycemia. And all these patients had normalization of blood sugar following resection. This is an interesting case. It comes out of the Canadian Respiratory Journal in 2016 of perineoplastic cough in renal cell carcinoma. This is a 62-year-old woman who presented with 8 months of severe coughing spells characterized by post-tussive emesis, night sweats, and weight loss. Was refractory to all sort of standard antitussive therapy, corticosteroids, bronchodilators. Interestingly, it did improve mildly with hydrocodone. During a pulmonary CT, she was found incidentally to have a 6.5 centimeter right renal mass, not abutting the diaphragm. This is an important factor because any sort of diaphragmatic irritation by the primary mass itself would probably exclude this as a perineoplastic syndrome. And following nephrectomy, her cough resolved in dramatic fashion. In the post-op bay, she actually had complete resolution. 11 cases, similar cases, have been reported in the literature. Again, they're typically refractory to standard antitussives, but they do respond to opiates. All resolved immediately following tumor resection. The proposed mechanism by which RCC can contribute to a perineoplastic cough is kind of vague, but the authors suggest it can be related to excess prostaglandin and IL-6 secretion, as well as bradykinin. Bradykinin, of course, being the enzyme associated with ACE inhibitor-induced coughing as well. This is an interesting case report, comes out of the Scandinavian Journal of Urology in 2009, of a case of perineoplastic gynecomastia in a patient with RCC in a GCH secreting tumor. This is a 60-year-old male, had a significant history of a left orchiectomy for undescended testes, who presented with gynecomastia. He actually ended up having not one but two syndromes. He had polycythemia as well. Following his nephrectomy, he saw a resolution of both his polycythemia and gynecomastia. Now, interestingly, this patient's tumor did not stain positive for beta-HCG, but his serum levels were elevated, suggesting that the tumor was indeed responsible for elevated levels. Moving on to the subset of neurological perineoplastic syndromes, there are a variety described in the literature, including limbic encephalitis, cerebellar ataxia, phrenic nerve paralysis, and ALS. As I kind of alluded to earlier, these are likely secondary to antibody and T-cell mediated responses to antigens shared by tumor and neuronal tissue. Diagnosis is aided by CSF analysis and the demonstration of autoantibodies, and generally surgical resection demonstrates favorable outcomes. This is a case that kind of goes outside of those rules that was reported in Internal Medicine in 2017. This is a 50-year-old male who presented with bilateral lower extremity weakness, muscle pain, and atrophy. He underwent some nerve conduction studies. These demonstrated loss of deep tendon reflexes. CSF analysis demonstrated elevated protein, but was otherwise normal. He ended up undergoing spinal MRI, which demonstrated thickening of his T8 nerve roots, and CT scan at the time demonstrated a right-sided renal mass. So here's his MRI sequences demonstrating thickened nerve roots, and then CT scan and histopathology consistent with RCC. So despite not having autoantibodies, this patient did receive empiric treatment with IVIG and steroids, and his symptoms resolved following nephrectomy. A case report of similar instances of demyelinating peripheral neuropathy in the setting of RCC is included here. Now, kind of in contrast to some of the other syndromes that I've spoken about, unfortunately, it seems that in demyelinating disease, tumor resection does not always lead to complete resolution of the symptoms. You'll note that only one patient in this series had complete resolution of his symptoms. The theory behind why they kind of hang on, even following resection, is there is likely some irreversible damage in that autoinflammatory process that is not healed completely, even with resection. This final case was immediately grabbed my attention. This was reported in The Neurologist in 2017. Sporadic Creutzfeldt-Jakob disease in the setting of metastatic renal cell carcinoma. So prion disease is something that's always kind of fascinated me. I've never heard of prion disease in the setting of any malignancy in the past. I always thought it was kind of its own thing that you get from eating bad hamburgers. And so I immediately kind of wanted to investigate this case report. So this is a 66-year-old male who presented with a month of focal left-sided numbness and loss of control of his upper extremity. Underwent an MRI of his brain. It demonstrated patchy areas of restricted diffusion in the cerebral cortices, which is what that looks like on MRI, apparently. He underwent a full-body CT scan and was found to have innumerable pulmonary nodules and a 5.7 centimeter left renal mass. This led the authors of the study to, to reasonably conclude that his neurological symptoms were secondary to his renal mass, and they started his workup for neurological paraneoplastic syndrome. So they performed an LP with CSF analysis to try to identify any sort of paraneoplastic autoantibodies. This was unfortunately negative. No autoantibodies were found. However, they decided to empirically treat the patient with steroids and IVIG anyways. Unfortunately, the patient did not experience resolution with this treatment, and he developed acutely increasing, worsening clonus and declining mental status. Finally, they decided to perform a brain biopsy, which is shown on the right, which demonstrated classic large clear vacuoles, which is pathognomonic for spongiform encephalopathy. This patient received the diagnosis of sporadic Creutzfeldt-Jakob disease, totally coincidental with his renal mass. And I wanted to include this case report because I think it's important that, despite the fact that there are absolutely a variety of very exotic and interesting paraneoplastic syndromes that can be associated with renal cell carcinoma, it's important to kind of acknowledge that just because a patient with a renal mass has an odd symptom, it doesn't necessarily mean that it's just because that it is a paraneoplastic syndrome. And so Occam's razor is not always correct, and to quote Hickham's dictum, a patient can have as many diseases as he damn well pleases. So the kind of question I kind of wanted to ask myself after going through all these cases is what's really the significance of paraneoplastic syndrome as far as renal cell carcinoma goes. So I wanted to look kind of as what sort of implication does it have with progression and prognosis of the disease. So in most of the textbooks that are kind of commonly out there, it's quoted that paraneoplastic syndromes are not proportional to tumor size or metastatic spread. They're not really always associated with poor prognosis. They do typically acknowledge that recurrence or persistence of the syndrome following resection is a poor prognostic indicator, but that's about it. Some of the literature, however, kind of disagrees with what is often found in textbooks. So this is a paper that comes out of Medical Principles and Practices in 2012 that asked a similar question. So this is a retrospective analysis of over 1,000 patients with resectable RCC and paraneoplastic syndromes. And they attempted to compare RCC staging at the time of presentation in patients with and without paraneoplastic syndromes, and they divided it between local and local advanced RCC. And they found that there was a relationship between paraneoplastic syndrome and a more advanced stage of disease, but it depended on the paraneoplastic syndrome you had. So they found that in hypercalcemia and in hypertension, there was a significant increase in the tumor staging at the time of presentation compared to patients who did not have paraneoplastic syndromes. However, this relationship was not seen in other syndromes examined. A more recent article published in the World Journal of Urology in 2015 kind of asked that question with an even greater patient cohort. So this was a retrospective analysis of almost 3,000 patients undergoing nephrectomy for localized RCC at Mayo Clinic between 1990 and 2010. And on univariate analysis, they found that paraneoplastic syndromes were associated with inferior cancer-specific survival, and they also noticed a trend towards shorter progression-free survival as well. On multivariate analysis, however, this relationship was not held up. It was found that worse outcomes associated with patients who presented with paraneoplastic syndromes were largely explained by adverse pathological features common in these patients' tumors. So this graph kind of better demonstrates what I'm getting at. You'll see that patients with paraneoplastic syndromes compared to patients without paraneoplastic syndromes at the time of presentation had more advanced tumor classification, tumor staging. They also had higher nuclear grades for Furman grading criteria for clear cell variants. They also subdivided patients as having any paraneoplastic syndrome versus symptomatic paraneoplastic syndromes. So some patients can have just laboratory abnormalities, not necessarily leading to symptomatic complaints. And they found that in patients with paraneoplastic syndromes and symptoms, there was a significant increase in tumor coagulative necrosis, as well as sarcomatoid differentiation in the tumor as well. The next kind of question I wanted to ask is, what are the perioperative implications of paraneoplastic syndromes? What are kind of the practical, takeaways can you use in kind of approaching a patient who has a paraneoplastic syndrome? So obviously it depends on what the syndrome is. So in patients with Stauffer syndrome, coagulopathy and poor hepatic synthetic function obviously has implications not only as far as bleeding goes intraoperatively, but also as poor albumin levels and poor wound healing goes in the postoperative setting. Anemia obviously makes patients more fragile to intraoperative bleeding. This is seen in a variety of patients, especially those with elevated IL-6 and ferritin and lactoferrin. Hypo and hyperglycemia requires optimization in the preoperative setting. Electrolyte abnormalities also require attention in the preoperative setting as well. And finally, I wanted to ask the question, is partial nephrectomy contraindicated in patients with paraneoplastic syndrome? So in essentially all of the case reports and all of the series that I evaluated in this, as I was going through the literature, treatment is always, radical nephrectomy. So I wanted to kind of investigate, is partial nephrectomy an option? So I did find one case report in which a patient with paraneoplastic syndrome underwent a partial nephrectomy. This is a patient with previously known von Hippel-Lindau syndrome. 49-year-old female presented with constitutional paraneoplastic syndromes, fever, anorexia, cachexia, and anemia. Her provider elected to perform a partial nephrectomy on her, which is traditional with patients with VHL due to their propensity to develop metasynchronous tumors in the contralateral side at some other point in time. And so she underwent partial nephrectomy. She did experience resolution of her paraneoplastic syndromes, and biopsy demonstrated a pretty advanced grade, Furman grade 4 RCC with extensive coagulative necrosis. While her symptoms did resolve, her hematocrit normalized, unfortunately 2 years postoperatively she was diagnosed with hepatic metastasis. Given that this is just a single case, I don't think that you can necessarily make any strong kind of takeaways of whether or not partial nephrectomy is a viable or a safe option in patients with paraneoplastic syndromes. Indeed, the advanced grade of her pathology certainly predisposed her to disease recurrence in the future. But I do think it's kind of worth mentioning that the vast majority of cases did undergo total nephrectomy. And the only case that I could find that underwent partial nephrectomy kind of had an adverse outcome. So, in summary, there's abundance of paraneoplastic syndromes associated with RCC. They come in all shapes and sizes. The prognostic implications associated with renal cell carcinoma kind of coincide with larger, more advanced tumor stage, worse nuclear grade, and larger tumor at the time of presentation. And finally, there are some perioperative implications and considerations to take away in evaluating a patient with paraneoplastic syndrome, especially if these abnormalities can be caught early and optimized in order to avoid any adverse outcomes. So, open up for questions or discussion. Mm-hmm.